10-inch blade serrated for the resin, very at least 2 inches. Oh my god. Okay guys, let's keep it down.
Hey guys, we need to keep the noise down, please, huh?
I think all of us, our adrenaline goes a little bit, but it is always surprising when you see someone come in and the knife is still in place.
Can you tell me your name? Are you okay? You understand what's going on? You want pain?
You're aiming a knife straight to the heart. You're attempting to do significant harm.
Wiggle your fingers on this side. I'll tracking my fingers. Squeeze my fingers.
Given where the knife was sticking out, it was remarkably stable. Now, whether that's just because the knife didn't go in far enough, we'll find out.
Okay, we'll get this sorted out.
So removing any knife right now was the wrong decision. He's going up to the operating room, and that's where it's the safest place to take it out.
They have to go to the OR.
There's no typical day in emergency.
What makes our job really neat here at Vancouver General Hospital is the variety. So we see young people, we see elderly people. We might go from seeing a patient who's suffering from a stroke and then move on and see somebody with a rolled ankle. We never really know what's coming in next.
Lower it down a bit, nice and loud.
People that I work with are fantastic. They're a big part of the reason why I enjoy working here so much.
Look at me. Hi. Calm down.
It takes a special kind of person to work full-time at Emerge, for sure. You have to think on your feet and problem solve, and you don't mind it when things get super wacky and you don't sit down for 12 hours straight.
Open your eyes. This is your last chance before we put a breathing tube.
Well, one of the lessons you learn in the emergency department is how unpredictable life is. It can truly turn and change dramatically on a dime and in an instant. We witness people whose life can turn completely upside down at a moment's notice, and we get to be there for them.
John. You know about Joe or nothing?
John,
Okay.
don't press my mouth. I'll just shut it. I'll pick up later.
Can I just find it, Kim? So I'm just gonna put this on here just for a second. So I have a young gentleman that has something called atrial fibrillation, where the heart is beating irregularly.
This morning, I woke up, and it's as if I ran a marathon, so my heart was just going off. So usually a heartbeat's 5. Boom, 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 boom. Right now, apparently it goes boom, 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 boom.
We typically don't want people to remain in this irregular heart rhythm for a prolonged period of time, so we're going to use electricity to change his heart rhythm from this irregular back into a normal rhythm.
Those are the pads that'll give you the little shock, right?
They knocked me out and shot my heart back to normal.
Put this on your finger.
Okay.
It's a pretty scary concept, and what the risk factors are, what could go wrong. We could give them entirely way too much medication and completely put you to sleep to the point of view that you stop breathing. Then there's a whole bunch of risks associated with that.
You've had this done before. Okay. So we're gonna give you some sedation soon, okay?
It seems actually quite blasé about it, more so than I would be. Okay, so we're going to go to sleep. Okay. Might sting in the arm a little bit.
How are you feeling there?
I'm just gonna come on 4 meters.
How are you doing, Jonathan? to yell at him a few times to remind him to breathe, which he did.
Jonathan, hold on. Hold on. 8 minutes?
And the patient can go home half an hour later after the procedure.
So your heart, does it feel any different now?
Actually, it's much better. Doesn't feel that stress, like after you did a long runner, or like after your heart run stress.
He's a little young to have this atrial fibrillation. He's got to follow up with a neurologist to try and figure out why exactly he had these symptoms.
I would buy out back early, I guess.
Sense of humor in the ER, I think, is essential. We make a joke that we're essentially preventing Darwinism, but there's some element of truth to that. It's hard to say the dumbest thing I've seen. A lot of people out there that aren't very bright.
She was on some monkey bars at a playground. Flipped backwards.
The emergency department attracts a lot of people that are doing, for whatever reason, very silly things.
Flipped backwards. Lost her grip. Fell back. Banged her arm.
And then her scalp rolled back. She missed her head.
I think I just snapped my arm. Although that's not really.
What are you doing, climbing monkey bars at midnight on a Friday night? You know, initially, you never know what you're going to get when the patient rolls through the door. She obviously had an arm injury, but we're looking for the life-threatening things, injuries that may not be that obvious. So lungs, the heart, the abdomen, the C-spine or neck.
And one more time, big breath in and hold it. So we're looking at your internal organs. Just make sure there's no bleeding in there. Our job is really to run through our protocol and just make sure that we're ruling those things out and making sure she's stable. So at the end, we're left with injuries that are more manageable.
Now move your hand back and forth. Can you move your wrist back and forth? Okay, sorry about that. Okay there?
Yeah, I'm good.
And we've done ultrasounds, x-rays, nothing else we can identify, so we're pretty confident that there's no life-threatening injuries here. She's going to have to have an operation to fix her arm, to repair this and wash it out and make sure it doesn't get infected.
My brother just broke his arm too.
Is this all an accident too? Is this a family thing? They recognize they've done something incorrect.
You doing all right?
Having the ability to laugh and say, you're going to be okay. And that goes a long way to reassuring them and making them feel better. Plus, you got to have fun at work.
Okay, this is a great series of ER videos. It's called Vancouver General Hospital, and there's a whole bunch of them, and there are tons of things. I mostly want to show you, obviously this is a trauma center, so that's kind of, in a trauma center, it's all crazy busy like that. Any ER is that. We could see any of that at Sequoia and have. So you go from something very traumatic that walks through the door, or that's life-threatening or dying, or you go out to somebody running in from the car saying, my mom's dead in the car. You go out there and you're trying to do CPR on somebody in a car, basically because it's impossible to get, it's hard to get them in, and of course they keep telling us we have to worry about body mechanics, but there's no way you can worry about body mechanics when you're pulling somebody out of the car. But the point of this is too, you saw the guy with atrial fib. His rhythm was normal, and then it went way too fast. A lot of times you would just give medication like DIG and the patient would be on that for a while and convert or slow down. You're not necessarily going to change that atrial fib. But in his case, it was too rapid and he was having other symptoms. So they shocked him. So that is a real scenario, even at in ERs all over. And they go home, which is amazing to me. You know, they get shocked, and then once the sedation wears off, they go home because their heart rate is back to normal. Then you also see the person throwing up in the bucket in the waiting room because they have nausea and vomiting, right? You see the broken leg. I didn't show it, but a girl that was just mountain climbing and had a broken leg. So it's just a broad spectrum of everything you see. So what I'm going to do, what I'm going to do now is go over a bunch of facts about the ER that people don't know what happens, not just patient care in the ER, but how the system works with everybody else's system. So if you have questions, just raise your hand and stop me, okay? Oh, I need to introduce myself. Where's my camera girl? Hi. Hi, San Francisco State Main Campus. I'm Sheri Sassarini, and I'm a coordinator here for the Kenyatta Group and a clinical instructor as well. ER nurse for 37 years and ER director at Sequoia Hospital for 10 years, and quit that 3 months ago, and I still miss it. When I see there was a fire truck out there, and I'm just ready to go out there and help. So, and I'll talk about that at the end. Once an ER nurse, always an ER nurse. Just like once an ICU nurse, always an ICU nurse. And I'll go into, you know, what it's like to be an ER nurse. But so Shay, let me.
I was just gonna say I saw that atrial fibrillation procedure at Sequoia. It's cardioversion, right?
Yeah.
And I was gonna compliment them. They fold up a towel a bunch of times and hold the person's chest down when they receive the shock, which I think is kind of nice. It seemed like I actually saw two, and both patients had concerns about how they would look to the people in the room when they were shocked and flailing, and that seemed to be like they were a little embarrassed about it. So I thought it was nice.
It is, and in that case, it's more in that setting. You were in the procedure room, I think, right? Yeah, that's a more controlled environment. And I mean, it seems like a simple thing to do, but honestly, it happens so quickly, and that patient is out. And then immediately, you know what I'm saying? So, but I haven't seen that procedure. This is not a brand new video. I think it's like 4 or 5 years old. So, but yeah, to me, it's constantly amazing how quickly you can re-snap the heart. You can really, you know, do it. And again, it's like 50 joules. It's not, you know, it's not like when you're defibrillating somebody at 360 or whatever. It's a really small amount, but it's enough to electrically kickstart the heart again.
Did you guys notice a funky O2 camera?
Yeah.
Did you wonder, you know what that is, right?
Yeah.
It's a CO2, right. So you're monitoring CO2 at the same time as your oxygen saturation. That is the expired CO2 that's being captured there.
Yeah, so they use it when you have to watch. It's not just like a cannula, it's different. You guys know, because remember, we didn't know what it was.
I was just going to ask you to repeat what she had said in the back so that they can hear.
Oh, she was just talking about how in the procedure room at Sequoia, she saw this same procedure with the cardioversion, and they put towels, you said, over the chest, so the patient...
And they hold the patient down really hard while they do the shock.
Yeah, so he doesn't flail like he did in this picture. But again, it's a very private environment. Not everybody's watching you do this or watching. It's just you and the doctor and respiratory therapist and the nurse, sometimes 2 nurses, because one is watching the monitor, one is taking care of the patient, giving drugs or whatever. So, okay, I am going to go seen number of ambulances. Number seen. ERs are different. It depends on if it's a trauma center, a big hospital. Level 1 is trauma, level 2 is like Sequoia, 24-hour ER doc. And we see probably at Sequoia 25,000 patients a year. So that can be anywhere from, on a slow day, 50 to a high day of 100. So, and that's in a 24-hour period, all different levels. Ambulances, probably 2 to 8 ambulances a day. San Mateo County sees about 125 ambulances a day. So that's how many ambulances are dispatched all over. Let me tell you about how the system works in San Mateo County. We do not have a trauma center in San Mateo County. Now, years ago, when I started there, we did. There were a lot of trauma designations. In San Mateo County, there were probably, you know, almost every other hospital was trauma. It wasn't cost effective. It wasn't doing anybody well. Most traumas are people that are indigent, have no money, drunk, whatever, a lot of major traumas. So hospitals, part of the trauma system requires that you have a surgeon in-house, an anesthesiologist in-house, and they couldn't afford it. You couldn't afford to keep them in-house for these patients that you might see in a trauma center. You know, in a big trauma center you see a lot, but in like Sequoia we wouldn't see that many. But enough so that, you know, it made it kind of crazy and busy at times. But anyway, they realized San Mateo County, it wasn't cost effective for anybody. So San Mateo County is cut in half at 92. The north of 92 goes to SF General, the south of 92 goes to Stanford. Those are the major trauma centers, okay? Just so you know, that's how it works. And that's how it works now in most big cities because it's easy to transport them, it's quicker to transport them than to keep a trauma center open, you know, and the cost of it. It was just really prohibitive. So, let's see, what else can I talk? Oh, did we get it yet? Oh, we did. Okay, great. County communications. So there is a county. Yeah, no, I'll take it.
It's an item already.
I got it.
The PowerPoint.
Did you get it? Okay. It's pretty basic PowerPoint. It's like my first one, you guys. So. You know how I am about this. So county communications is the hub. That is where, like, and I'll go through this. Like, if you call 911, okay, you're out here, you call 911. Then it goes to dispatch, the 911 call. Dispatch is a group of people, probably like 15 in a room in San Mateo County, and they get the call. Okay, and then what they have to do, it's a big, huge system, is say, okay, it's, let's say it's here at the campus. So what they do is they look to see where all the ambulances are in the area, or the fire trucks, the closest fire truck. Because remember, a fire truck responds before an ambulance. A fire truck is loaded with paramedics now, they're all paramedic trained. Then the ambulance shows to transport. So the fire trucks, because we have fire engines on every corner all over, as you see, they're the guys that respond first, okay? So then the fire truck comes to the 911 call, responds, evaluates the patient, decides, okay, if they're okay or they don't need to really do anything with the patient, then they leave. But for the most part, they get transported. Now the ambulance shows up, and they're paramedics as well, and they all work together, and then they put the patient in the ambulance goes to the hospital. The paramedics call the hospital, the ER, and say, we're coming, code 3, code 2. Code 2 is just a regular call. Code 3 is a code blue call. It's like lights and sirens, CPR, you know, stroke, STEMI, all those kind of things. Okay, so then the ER nurse gets that call, tells everybody, because the flashing lights and the beepers go off so everybody knows. So then you immediately have to get a room ready wherever you can. Means you have to bump some patients out of rooms, put them in hallway, and get the main room ready for that ambulance. If it's just a nothing ambulance, you know, it might be a drunk on the street with nothing wrong, then those people that bring in those patients, those paramedics, and there's no room, they have to sit and hold the patient. So there's no transfer of care until that patient goes to a bed in the ER. So that patient might come in on a rig, a gurney, and sit in the hallway until there's a bed available. They hate that. Sometimes they like it because they go in the back and have coffee and it gives them a break. But the patient is really still theirs until we transfer it to our bed, okay? So anyway, so then the patient comes, the paramedics call the ER, say I'll be there in 5 minutes, 2 minutes, whatever. They give you a little bit of lead time. Then the patient arrives, and again, depending on the acuity of the patient goes to a regular room or they go to a code room, a busy room, okay? And then the care starts in the ER. So that's a little bit about how it works out there in the field. And usually, it's hilarious because the paramedics who in the ambulance have brought the patient, hang out, because everybody, they all want to know how the patient turns out, especially the STEMIs, which are the heart attacks and the strokes. But the fire trucks, this always cracks me up, that they all come in with a big old friggin' fire truck. You can only imagine how much that costs, to the ER. They all come because they just want to find out too. Plus, they're not that busy and they're just doing something. So it's hilarious, but it's such a, like I said, it's such a close-knit group, and you know everybody. You know, in the ER, you know the firemen, the paramedics, the local police, you know everybody, because they're in and out all the time. Okay, walk-in, how a patient enters and leaves the ER. Okay, a walk-in, as patients do, they walk in. Now, a really sick patient can walk in. A heart attack, a stroke. People don't always call the ambulances. A lot of times, people, oh, I don't need an ambulance, I don't need an ambulance. And so they just come in on their own or have a family member bring. But there's an intuition of an ER nurse that you can look at somebody and go, oh my God, they're sick as shit. Oh my God, put them in, get them to a room right away. There's something wrong. No, I'm serious. You just have this, you have this assessment skill. And I don't know, my people might know it. I would say, did you notice their pupils were different? No, I didn't know. Because you just notice everything about patients. Because that's what you do. An ICU nurse can tell you everything about lab and pathophys. An ER nurse just can tell you the basics of taking care of somebody that is dying and shipping them out, okay? Anyway, so ambulance, police. Okay, the police a lot of times will bring patients in that are on hold, that are going to jail, but they have a medical issue. So they have to have a medical clearance before they can go to jail. So the police will bring patients into the ER for that. And a lot of times it's chest pain because they don't want to go, I mean, there's not always, they kind of sometimes make up stuff a little, but they have to take care of it. They can't just take him to jail and find out the guy dies in jail because he had a heart attack. So we will take care, and they all come in and they're usually handcuffed. Actually, they're usually the nicest people. So now, transfers, types of transfers. I'll quickly go over this. Pediatric transfers. Every hospital that doesn't have peds, and there's a lot of hospitals, peds, there's not a lot of spots for peds. Well, we stabilize, hold them, we'll do whatever it needs to do to get that patient ready to transfer, but we have to wait for a transport team from Lucille Packard. We have to wait till they have a bed. Sometimes they don't have a bed, so we're holding these patients for hours and hours and overnight. And we have to wait for the critical care transport team shows up, and they transfer. So it's a formal thing, is a transfer, and the paperwork is all done, and you basically, because we're not a pediatric facility, unless it's under 1 month, if we do have a baby, we can put them upstairs to the Lucille Packard nursery that Sequoia has. So those have to be transfers. Psych, we don't have a psych unit anymore. Psych is one of the most difficult places for placing patients because there's not a lot of psych facilities at all, especially adolescent psych. I think there's only one spot. So a lot of times, now if it's a 5150 that is unstable, we can admit to ICU, and then they're watched, in ICU because they're watched as a one-on-one, but eventually that patient has to be transferred. But if it's just a patient that's stable that says, I'm suicidal, and I need help, we have to find them a bed and transfer them, okay? And again, it's really difficult. There's not a lot of psych facilities that have beds available.
Yes? Isn't that within a certain amount of time as well, the 5150s, within like 24 hours or something like that they need to be transferred, or is there
no
time?
There's no time.
No time.
But when you're on at 5150, you have a 72-hour. And so it starts once the ER doc puts the hold on. But we want to get them out of there, trust me. We don't have the manpower to watch these people or to, spend time, especially if it is somebody suicidal. It was so great when we had a psych unit, trust me, it was the best because they were so good at taking these patients and we could admit and it was so much easier. So that's one of the big transfer things. SARTs, do you guys know what that is? Okay, that's do you know? Anybody know? No. Sexual Assault Response Team. So if you have somebody coming in that's been raped or attacked, and they want to file a report, or what you do is you call this team. Simply because it's a special training. We used to do it in the ER and get the training, but it takes a nurse, pulls a nurse way out of the line of fire, and you spend a lot of time with this person, and you don't have that staff in the ER. So the SART team comes, and they come from San Mateo County, and it's a team of nurses, and they treat these, it's wonderful actually. They know what to ask, they know how to collect evidence. That's another thing that's huge, and how to do the exam. So they'll come and either see the patient in the ER in the room, or if the patient's pretty stable and okay with it, they'll transfer them to San Mateo County General, and then they'll do the exam there. So that's the SART team. Trauma. This is a brand new thing. Actually, it's not brand new. It's probably now probably 10 years old, 8 years old. Trauma transfer. So believe it or not, in the ER, we will call a trauma transfer. If we call 911 from the ER, Sequoia ER, mind you, we have ER docs, we have everybody, we can take care of traumas. We can take care of them in the ER. But a trauma transfer can get that trauma patient to Stanford quicker than I can get a surgeon in or an anesthesiologist in. They transport 911, they can be at Stanford in probably 10 minutes. And there's a direct contact from the ER doc to the Stanford ER doc. We're transferring a trauma. Now, do you know what designates a trauma? Mechanism of injury. Mechanism of injury is how the person was injured. So if you were hit, you're at a stop sign, and a car hits you from behind and they're going 2 miles an hour, there's no mechanism, really. That's pretty easy. But if the car slams into you at 80 in the back and you're smashed in your car, that's a high mechanism of injury. So that would be considered a trauma transported. If somebody falls off a roof and impales himself or has major fractures, that's a trauma. So it just depends on what happened. If they get stabbed, shot, gunshot wounds, those are traumas. But those get transferred. So it took our ER docs a long time to kind of say, oh, we're going to transfer this, because they're so used to taking care of these patients. But in reality, they get better care when they're taken to Stanford, because the whole team is ready for them and all that kind of stuff. So it's a kind of a new weird thing. Okay, next slide. I'm going to be talking way too much here. Okay, like I said, you can walk in the ER. Now the roles of the ER staff, you can see I probably could have bulleted some of these, but oh well. The ERMD, he's on 24 hours. They do have PAs now that come in the middle of the day that will take the non-urgent type things, the sore throats, the sprains, the lacerations, that kind of stuff. And they might start somebody that's a more advanced, but the ER doc is in command of the whole department. They're wonderful people, they really are, and that's one of the relationships that we all have with them is, we don't, there's so much, pretty much standing orders in the ER. So you come in with a chest pain, the nurse gets your EKG, starts your IV, draws your blood, before the doctor is even near the room. So a lot of that goes on, and that's the relationship that happens in the ER, and has to happen, because to keep things going. Okay, there's a triage, there's a charge, let me do the charge nurse first. The charge nurse is the person, she kind of is overseeing the whole department. She tries to get admissions up, she sees what beds are available, who's moving in, who's moving out, so kind of the overseer. I think the triage nurse is probably the hardest role to play. That is the person that has to decide, okay, you're gonna look at that patient, oh, they're sick, let's get them in a room right away, or that patient can go in the waiting room. A triage is basically there's 3 types of assessments that you do, primary, secondary, and tertiary are real assessments. Primary is what a triage nurse does, and they basically just oversee, look, figure out what's going on. 3 minutes. You shouldn't spend much more than that, because you just are assessing quickly where in line this patient goes. And again, some patients will go in quicker ahead of others in the waiting room because they're not that sick. I mean, it makes sense, right? So then the patient goes to the room, is assigned to a room, and the room nurse, and each nurse ratio is 4 to 1 in the ER, unless they're really, depending on acuity, will have 3 or 4 patients in rooms. And that nurse will immediately start a line, O2, draw blood, do whatever it takes, put an NG, do what it needs to do right off the bat, okay, to get going with that patient. Because you want to get the labs back, you want to get the x-rays back. You don't want them in the ER forever. You want them in and out as quick as possible. So you draw blood right away and get it ready to go down to the lab, okay? And then we have an ER tech on nights. Now they're kind of starting to put them on days, and they're mostly to, do scrubbing of lacerations, clean the bed, do EKGs, transport to CT, that kind of thing is an ER tech. And the ACs are the secretaries at the desk, and I think they're the best in the world. They're command central, and they pretty much know where everybody is, what's going on, and what's happening. Plus, they have to be nice when they answer the phone. They, they're meters and greeters. Okay. Sepsis. This is a brand new big one. Actually, it's probably been 5 years now that they used to admit people with like a pneumonia or a urinary tract infection called urosepsis, and there wasn't a protocol. Now, they realize that septic patients, their lactic acid increases and they die. They're not treated like they should be. They're not given the fluids, they're not fluid resuscitation. That's not done. So now, there's a sepsis protocol. So if a patient comes in and has like high temp, high blood pressure, rapid heart rate, like 3 basic things, then you immediately start the sepsis protocol. So the triage nurse is responsible for starting the sepsis protocol.
So Sheri, can I say something? So that is one of the critical care bundle I put up on the document, and that is what Sheri is talking about. Yeah, look up.
Yeah, it's a real, and it saves lives. I mean, we're doing things totally different than we did before with this sepsis bundle, but it's really working. It's saving lives. Where they might be admitted to a floor instead of ICU. They get admitted to ICU if their labs show it, indicate it. STEMI. Do you know what STEMI is, you guys? ST elevation MI. Okay, that's what STEMI stands for. That's a heart attack, and that's a serious heart attack. And there's a whole protocol for that as well. And Sequoia, most hospitals now are STEMI certified and stroke certified. So you have to go through a whole process of having everything in order to take care of a STEMI. So in a STEMI, part of the process, the nurse does the EKG in 3 minutes, and the door to a drug time to the cath lab is 20. So when you get a STEMI, you immediately run quick to get that patient to the cath lab to open up that vessel, which is of the patient having a heart attack. Now, the paramedics now, too, since we're STEMI and stroke certified, when they get a STEMI in the field, they immediately send us an EKG and say, we've got a STEMI, and right away we call the cath lab even before the patients arrived, because we know the patient's having a serious heart attack, and you want to act as soon as you can. So STEMI. Stroke, we're doing that for stroke as well. So if a patient is cut, that paramedics will call and say, we have a stroke patient, we have the same kind of protocol that we do to take care of that patient. And again, it depends on when they had the symptoms, what symptoms they're having, all that kind of stuff. Okay? So that's another thing that would be good for them to know, the stroke. Epiglottitis, do you guys know what that is, you pediatric kids? Yeah. That's a serious PD emergency. And I've only actually seen one once, and they have a high-pitched whine, and they're just really, really sick. So you don't want to excite these kids. You want to keep them calm, but you're still nervous as hell because in 1 second they could stop breathing. I mean, it's a really scary thing. Pulmonary embolus. You guys know what pulmonary embolus is, right? It goes to the lungs like a DVT or whatever. Do you know what lab you're supposed to look for? What's an indicator that you have a PE? It's called a D-dimer. And a D-dimer is protein-based, and that means when you're clotting, your protein increases. There's a certain kind of thing that increases in your blood, and if that is positive, that indicates that you might have a PE. And then they do a VQ scan, CT, and to show that, yes, in fact, you do. So that's one of the ectopics. Ectopics happen, they're serious emergency. They can be they can be stable and very unstable when they come to the ER. So it's something you have to act on really quickly. Dissecting aorta. This is scary as crap. As somebody comes in with back pain, sudden back pain and drop in blood pressure. And you just, again, go by history, they go to CT and their aorta's wide open. Now, you can take them to surgery and save them, but it doesn't happen that often. It's really not a good sign. And a lot of time, again, it's a mechanism, if you smash, it's a deceleration injury or whatever, and it cracks open your aorta. But it does happen more often than you think, but it's a scary thing. And I've seen where they've actually sewn it back together, the aorta, and fixed patients, if they get to the OR as quick as possible. Code blues, you guys know what a code blue is. And we get those a lot. CPR in progress, coming in. We do save a lot of lives. I mean, it's amazing. They don't all die. With all the stuff it depends on how quickly they were responded and resuscitated in the field, and then how quickly, the minute we get in and take care of it, and people do live. The ER docs and the ER staff respond to code blue in the hospital. So if there's a code blue up on the floor, the ER doc runs up there Actually, it's after hours now, because the intensivist does it during the middle of the day, but
I was in the ICU last night, and they called a code blue on the patient that I was with. So the ER docs did come up, and we did CPR and stuff, and they saved him.
Did they? Did you?
A lot of CPR, yeah.
Did the patient live?
Yeah.
Oh, God, you have Damon.
Yeah, so I was actually just going last night just to meet him for the
Yeah.
first time, and he's like, hey, you want to stay? So I stayed for like 3 hours and helped take care of the patient, but it was...
So what did you do?
She was stabilized.
No, we all
Did you
did.
do the chest pump or the?
Yeah, I did compressions,
That's awesome.
which is so difficult. I'd never done it before. And
Yeah,
it was a really big guy.
That's why they rotate
It was
usually.
so hard.
Yeah.
And the bed was a little bit too high, so I feel like I was...
Did they put a stool? Because a lot of times they'll shove a stool.
No,
in.
they put the thing under his back and stuff, but it was really like, I was like sweating and like, it was really good.
But you saw the team, right?
Absolutely, it was so calm and
Yeah,
like,
and
it was
organized
just so like
chaos.
methodical, and I never seen a coach before, but it was like,
Yeah.
I don't want to say perfect time, but to learn, it was great.
Oh, yeah. No, it's just, it's amazing. And you think it looks like a big disaster zone, because there are people, but everybody kind of knows, okay, if you're doing this, I'll do that, or blah, 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 and somebody will yell out what to do next. Which ER doc do you remember? What did he look like?
I think Oldham came up.
Oh, George Oldham.
Yeah. Glasses.
Yeah.
He wasn't up for very long, because he had a PEA, the patient, and so they gave him a Epi and stuff.
Yeah. See what I mean? So it's hard sometimes for the ER doc to get up there, because he's got an ER full. So a lot of times the ICU nurses too, they're used to running codes, so they might start something. I mean, of course they will, and then the ER doc gets up there and oversees and stuff like that. So yeah, it's it can be again, some days it's like a fireman. It's dead slow in the ER, but then all of a sudden it takes off, and you never say the Q word like everybody knows. You never say that. Okay. The tamponade obviously is a pressure on the heart so it doesn't beat correctly. Blunt trauma is somebody that, again, gunshot or knife or a stab or whatever, and you don't pull anything out. If something's impaled in somebody, you never pull it out, because basically that's tamponading whatever is in there. And the minute you pull that out, it could hemorrhage. I mean, it could be a holy disaster. So they go like that to the OR. And they look so, it's just a scary sight, but that's how they go. Super infections, I've seen somebody that had like a staph infection. A staph is a skin infection on their arm, and it's a small wound. All of a sudden, for some reason, it goes into his system, in their body, and within probably half hour they could die if you don't treat them. And they turn purple. They get blotchy skin, and you have to, and strep. I've seen somebody with a full body strep infection from a wound. So it's a weird dynamic, and it's quick assessment and quick IV antibiotics, quicker than you can imagine. A broad spectrum, every kind you can, because they could turn into a huge, 10 times worse than what they are. And then pneumothorax, and we see those on the floor. That happens. Okay, next. Oh, challenging patients. Okay. Challenging patients sometimes are hard for us in the ER when you're taking care of people that are really sick. You just are, and saving lives, and you see people that you really want to care for, and then you have patients that sometimes your whole heart isn't into it, but they still deserve 100% care as well. The chronic pain patients are really difficult a lot of times because they keep coming back. And they are in chronic pain and they have issues, but as an ER nurse, it's really difficult to feel compassion for these patients that keep coming back, and you can't give them enough drugs. You can't give them enough meds, and you're not going to take care of them, and it's really not the place to do some psychology with them. We try to refer them to chronic pain places, but they're just difficult patients. Cultural differences. A lot of times, even though we've gotten to know which patients are more whiners and which ones are more stoic and all that kind of stuff, but even so much as a Hispanic mom with her baby, they will wrap the child in 20 blankets and they've got a fever of 104. And we're like, no, please take the blankets off. Although they're saying just ignore it now because it's not worth hassling with the poor mom, but it just makes the kid even hotter. But in their mind, that's what the thinking is. Keep them warm, keep them warm. Remember, we talked about this one time. But now they're kind of letting go of that. Drug-seeking behavior, again, you know who the returnees are, or the, what's the word? Frequent flyers, yeah, which is a terrible ER thing, but that's, you just know. And in the county now, we really we communicate with the other ERs about so-and-so, he comes in for blah, 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 don't give him this, da-da-da. And the ER docs will stop giving them, because they know what they want. They're always allergic to Advil, Toradol. They're always allergic to the basic things that you would try first, for whatever reason. So, again, they deserve care. Everybody that walks into the ER gets care. You cannot refuse anybody. You cannot refuse. It's against the law. You have to treat everybody that comes in to be seen. Access issues. This is really, it's a part of education as well. There are so many people out there that don't have doctors, don't have a way to get a doctor, can't, for follow-up, we take care of somebody and we try to give them as much antibiotic, as much, like I will give, like lacerations, I'll get bandages, I'll steal from the cupboard, give them as much as they can, because they will go home and they won't have any of this, and they won't get a follow-up. We refer a lot of people to Fair Oaks Clinic. Well, there's no appointments for 2 months. So they come back to the ER. So the ER is their doctor. They'll put George Oldham as their primary care doctor. He's one of the ER docs. You know what I'm saying? Because and they won't hear you when you say you can't be doing this, you can't, no, speak. And they know what you're talking about, But you see them anyway. It's just so sad because they just don't have any place to go. Very minor, okay, and very bizarre. We see some crazy bizarre patients. Snake bites, this is a funny one. We actually have a snake bite kit, and you have to keep it up to date. Every summer we have 1 or 2 rattlesnake bites. And so you have to treat them with the anti-venom. And a lot of times if we run out, because they need a lot, we have to send a taxi or a police officer to Kaiser or the next ER to get more venom to give to them. So it's one of those high-risk, low-time, and one of those things that you hardly ever do, but you have to be prepared for. Spider bites, poisoning. There's a lot of poisoning of ingesting, like children ingest things in the cupboard or whatever. What do you think is the number one thing that you don't want to be poisoned by? The worst over the counter thing.
Drano.
Probably Drano, but Tylenol. Tylenol is the worst medication because you can go into liver failure in a very short amount of time. You can take as much aspirin, you'll just bleed a little bit. You can take Advil, but Tylenol is by far. And we do the minute they come in, you just start a protocol right away with that because that is a really, really bad drug. Foreign objects in odd places. I can tell you how many times, I'll never forget this is really gross, but you would not believe how many times things get stuck up rectums. And I'll never forget this one time, it was a water bottle, like this, and the x-ray said, please recycle. I'll never forget that. Like we were going to take it out and rinse it and use it, Anyway, so, and it's amazing. And those usually have to go to surgery because you can't pull them back down. So they end up getting a major surgery to get that object out. And then kids will put things up their nose and in their ears, and so you're always trying to get stuff out or to take care of things. But funny place. Burns. If there's a major burn, it goes to St. Francis. You always transfer to an area that can take care of really bad third-degree burns. And as you guys know, it depends on how much of your body gets the burn and if they're first, second, or third degree. A tar burn. The ER gets tar burns all the time, where guys are working with the tar and they get it all over their body. And that is another burn, but the hard part with tar, you have to have like mayonnaise to take it off, the tar off their skin. Because you have to remember, it sticks. And you can't take care of a wound, you can't just rub it off, because that's just going to peel more skin off. So you have to get that tar off. I remember one time, it took us like 8 hours, I swear to God, this poor guy, to get the tar off, before you could even take care of the burn underneath. So So fractures, get a lot of fractures, you get a lot of shoulder dislocations. I always have had the hardest time with orthopedic injuries because to me it's so barbaric. You know, they just pull and stretch, and the orthopods will hit them on with a hammer, you know, but it's a weird medicine. But if it's an open fracture like that girl had, you know, who was drunk and happy, and she's going to be hurting so much when she comes out of it, let me tell you. That's a big deal. Has to go to surgery, has to get antibiotics, has to be washed. Open fractures are really dangerous for infections to set in. So, alcohol. Lots of alcoholics that come in. The same ones kind of return, and they want help, and they want to sober up. And you do the best you can, but they come back a lot. A lot of times they're really, really sick, and they get admitted. Sometimes you just give them food and new clothes and send them back out. And then they'll show up somewhere else a lot of times. It's a sad disease that people, you know, there's no follow-up. There's no place you can send these people.
They have alcohol poisoning, what do you do to treat that?
Well, it depends on how bad they are. I mean, if they're on
really
comatose, you're going to intubate and put them in the ICU. But if they're just somebody drunk, you can't send them out with a BA that's elevated, so you have to hold them in the ER till their blood alcohol level comes down. So again, we feed them, give them clean clothes, just watch them until their blood alcohol comes down. It takes up a spot. I mean, it's a really difficult thing. And those guys usually are in the hallway in a gurney because you'll need their room. But it's sad. There are some places that we can transfer them, but usually they want the alcohol level down. You know, they don't want to send somebody out. We can't send somebody out that's really drunk. Now, people can walk out if they want to, if they choose to do that. We can't force somebody to stay. And that does happen. We do call the police and say, so-and-so is drunk as a skunk, just walked out. You might want to pick him up. And then they'll pick him up sometimes at the end of the street and take him to an alcohol detox place or a
Some
drop-off
sort of
center.
consent or something for them to sign before they walk out?
No, if you can't catch them, they walk out. So, I mean, there's nothing you can do. You're not going to stop somebody. If you can get them to sign, if it's somebody that is of a right mind, then you have them sign the form. But it wouldn't do you any good to have a drunk sign the form because he doesn't know what he's signing, and it's not fair, right? Okay. Respiratory TB, hyperemesis TB. This is always a joke, just like MRSA. We don't really know. So in the ER, we just assume by assessment, okay, they've been traveling in which country, and they're coughing, and they look disheveled, they've been living in the street. So you kind of think, okay, might have TB. So you try to be, you know, try to isolate them to an area, you put a mask on. But you really don't know until they get up to the floor and then find out, you know, and then all the ER nurses have to be tested again, and it's a big circus. Hyperemesis, those are the pregnant ladies that just keep throwing up, and they come from their doc because they just need some IV hydration. And we take care of those too, if they can't go up to the infusion center or someplace else to get the fluids. But I'm just trying to go over SVT, just like what the guy had. You know, we get patients, he had rapid atrial fib, but we get patients that come in walking with VTAC, and you know, you just have to take care of them and treat them quickly. Angina, as you know, stable and unstable, we take that. Okay, clicks. I got to talk quick here. Elderly, what you see mostly with the elderly is sepsis, like I talked about, uro or respiratory fractures, hip fractures. It's kind of a death sentence for a lot of old people. They go in with a hip fracture and they never go home because it's really hard for them to get back into shape. It's a sad thing. Failure to thrive. Little old people that don't all of a sudden have given up and they don't want to eat or drink, or they don't have somebody taking care of them. I remember one lady that came in and, oh my God, she had to be 90, and her sister was keeping her under the bed on the floor. And it was just the saddest story. And the woman was awake and alert when she came in. She was really bad, and she died like the next day. You know, just because, and nobody's watching this stuff. You know, I mean, and what do you do? It's just so sad. Children. Respiratory, children primarily are respiratory. Children are really difficult for always that come into the ER because they're usually very, very sick. And especially by ambulance, and there's only so much you can do for them. so that's a really, we all have a sad children's story, and I'll tell you one of mine, I'll remember forever. It was when we were still a trauma center, and it was this young kid, he was about 8, and we got a call that he was coming in, he was on his bike, and that he'd been hit by a semi-truck. A truck had backed into him, and he rolled under the truck, and the truck had driven over him. And we got a call that he was coming in by code 3 by, the paramedics and firemen, and they had put the mask pants. The mask pants are those, remember those? I don't know if you guys, they're using them now again, actually. And it basically would, you put them on and it would squeeze, just like a tourniquet. So the blood would stay up in this part of the body. So they had put these mask pants on, and they told us that, this kid was basically his degloved, which means his skin was wiped off, was torn down. But we didn't know because he had these pants on when he came in, right? And so we put him in the room, and there was a surgeon there, everybody was there, and because it was a trauma. And he was talking to me. Oh, am I going to be okay? I went tell my mommy I'm here, and blah, 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 blah. We took the pants off. He had literally nothing left from his waist down. It was totally gone. And he went to surgery, and I'll never forget, I was getting chills. And he says to me, am I going to live? Am I going to live? And he died in surgery. And everybody and their brother they worked on him for like 20 hours. Plastic surgeons, vascular surgeons, everybody they could to put him back together, but they couldn't. So, that's when you have those stress debriefings, after you have a case like that. Because who was affected? One of the people that was affected the most was the lady in the blood bank, because she had to turn over something like 50 units of blood for this child in the OR. And you wouldn't even think of that, but that's how it affects everybody in a hospital. So that's why a lot of this stress debriefing is really important for cases like that. Okay, and the joke is vet medicine. Kids are vet medicine, as you guys know, you've heard that. So about 20% of what you see in the ER, so we had 100 patients, about 20 of those patients would be admissions. Admissions take a lot of time and a lot of work for the ER nurse. And unfortunately, the relationship with the floor a lot of times is not as perfect as it should be, because the ER nurse basically is just going to get that patient stabilized, draw the blood, put the IV, put the Foley, do what you need to do, and then get that patient upstairs. They're not going to do 100% of the assessment either. They're only going to assess what they really need to assess. Question?
What is vet medicine? I don't know if I...
Veterinary medicine.
Okay.
So having kids are just like, taking care of a kid is like taking care of a dog or a cat, because a lot of times they can't communicate. Okay. So you're treating symptoms. So that's an ER joke. Okay. You guys didn't know that?
No, right there.
Well, because it is. If you think about it, if the baby can't communicate, you have to assess that child in every aspect to find out why. What's going on with this kid? It's just like a puppy. You don't know if he ingested something, just like the kid. Okay. So the county, ERs, all ERs in a county are really involved with the county, everything in the county, everything you have to do with the county. So an ER, in the ER is a big computer screen that has all the emergency rooms in San Mateo County. Kaiser ER, Peninsula ER, it has a screen. And it has what their status. Are they open? Are they green? Are they black? Are they blue? Whatever their status is in the ER. Are they overloaded? Do they have too many ambulances? So we all know this. But they also, when you have a disaster drill, they will code us. They will ask us, how many patients can you take? What's the ring down? If like the airport, when that plane at the airport went down, they go out there and say, how many can you take? Immediates, delayed, and you have to give a number. I can take 2 immediates, 2 serious ones. I can take 3 delayed and 5 non-acute. And that means that you would have to cram those patients in your ER. You got to help, and you have to tell them what you can do. So we communicate every time there's a major disaster. If there's an MCI, mass casualty incident, NCI, mass casualty incident, which happens a lot, where there's trucks, there's auto accidents, and there's 2 or 3 or 4 victims, then they poll us then too, and we'll know about that. We'll get a ring down and be told, okay, on 92, blah, 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 da, 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 da. So then they'll poll us. How many can you take? Be ready. reporting of any outbreaks. Oh my God. So the swine flu, what was the other, the N1, what was the N1? H1N1, the regular flu, the measles. We have to report everything. We keep track in the ER of how many we see, and we have to report to the infection control people in the county. So those are things that the ER does too. They keep track of all that. Okay, I talked about county communications. STEMI and stroke certificates, we have to maintain those. We went after those. We could show that we had a cath lab team for the STEMI. We could show that our times were really good. We have to see X amount of STEMIs to maintain that certificate. Stroke, you have to get them to CT as quick as you can. You have to give them the GPA if you're going to within a certain amount of time. All those kind of things, and there are guidelines throughout the country. It's like I said, a major certificate, but we have to maintain it. We have to show by our patient care that we can still do it. So it's a big deal, and it also makes us look good as a hospital. You want that. You want the strokes. Like San Mateo County General is not a stroke or STEMI certified. So those patients don't, if ambulance picks up a STEMI, they won't go there. They'll go to the hospital that can do the STEMIs. Okay? And EMS meetings, we have meetings 2 and 3 times a month where we meet with all the people from all the county, the firemen, the police, the ambulance, the Red Cross, all this kind of stuff, and coordinate everything. We do have disaster drills all the time, like 2 or 3 times a year. There's a statewide, and you get victims, and you pretend, and you set up a tent, a triage tent outside the ER to pretend if you got a bunch of victims. So we go through that role, so we're prepared. So you'll hear on the floor, that they're calling a disaster drill. They really want you to think about that because we could use your help, but we act it. In the ER, they act it. They go through the role of getting patients, of what you would do, of, how are you going to treat this? Is it an earthquake? Is it, what kind of patients are you going to expect? Is it a poisoning? Is it a gassing? Whatever. So I think is that it, Missy?
Did you have anything for Ebola?
Yes, there was an Ebola training throughout the hospital actually, and what we would do, and the patients actually would come. There was one room in the ER designated. Some patients would go there or go directly to ICU, to one area in the ICU that was isolated. Nurses, certain nurses were trained to take care of those patients. You have to act because you just never know, especially here in the Bay Area, because they come from all over the world in this area. You know what I'm saying? We're like a hub. So yes, there's always going to be training and preparation. That's part of the whole EMS thing, and that's a requirement of the ERs to be ready. Okay, so this is a little fact, and I think I might have the 5 wrong, but who knows? I just know that for every hour a patient sits in the ER, once they're admitted and you can't get them upstairs, their discharge is delayed because their care is not. They should be up on the floor being cared for and taken care of. In the ER, they're only going to get what we need to do to take care of them, stabilize them, but they need their care and they need to get upstairs. So that's something. This is my big thing: is the overcrowding of the ER, is pushing them up. ER has limited bed space. Flow needs to move. Hospital system must be in place to help. A surge capacity plan must happen to make a safe environment. In other words, there's got to be a system in place. It's why I think they call Code Red triage or something. It worked for a while, but it's not working as much as it did before. And that means that ER's overloaded, and we might have 4 admissions that need to go up, and nobody's taking them. Nobody's taking them because you want to wait for the other nurse, or for whatever, or we're out of ratios. Well, ER is never in ratio, and we can't do anything. We have to take these patients and take care of them. So the floor nurse needs to go out of ratio for a short amount of time until somebody comes in. It depends on who's up there and who's working. Some of them are much better about taking patients. Some are, more understanding. But in the real world, I would love them to come down. Just like now that the clinical ER nurses are clinical faculty, we really see what it's like on the floor and how bad it is and how crazy it is and how it's really nice in the ER because we have our ER doctor and we have standing orders. So we do a lot on our own. Up there, they have to call a doc and wait for them to call back. So there's issues on both sides. I just think people should live in somebody's shoes, and I've forever tried to get some of the floor nurses to come down and look at the ER when it's really busy and see how bad it is, and see that in the waiting room people are throwing up in cans, and people are laying on the floor because there's no more beds available in the lobby. but it still hasn't happened. Okay, this is more blah, 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 blah. Okay, camaraderie. Again, that's what happens in the ER, and I think that happens in ICUs and certain, everybody, you build a camaraderie with the people you work, and we have a camaraderie with the people in the county because we get to know them really well. Gallows humor, I think I told you guys, one of the things that you see all the time in the ER is a wedeo. Do you know what a wedeo is? Didn't I tell you this? Weak and dizzy all over. And that's what people, that's the wedeo. Yeah, it's a joke. I mean, we call them wedeos because they're people that come in and weak and dizzy all over. And then, and you're like, oh, for God's sake, please. In fact, there was a patient the other day, because I was in the ER the other day to get my dose of it, and the patient came in and said, I think I'm nauseated. Oh my God, please go home. But you have to see him. So, and then this is an all-time favorite, an old friend of mine. This is from years ago, this one. F-O-F-O-F.
Oh, I get it.
Fall on face on floor. That's funny. So that's it. And just like LOM, you got LOM and and what is it? What's the other one? LOL. LOL. Yeah. It is little old lady and little old man. Just so you know. FLK is funny looking kid. I shouldn't have even told you guys that.
That's hilarious.
I know. Okay. So it is true when he said there is a gallows humor, and it's not, and it's only, it really is just to keep you going under conditions that can be horrific sometimes. But sometimes we need to keep our mouth shut. I know that. That's what the manager walks around. It's a fishbowl. Lives you save. That's such a good thing. We had a guy that comes. He still comes once a year because we saved his. He had a heart attack 10 years ago, and he comes every year and brings a big thing of fruit. So those kind of things are really. It makes it really worthwhile. And once an ER nurse, always an ER nurse. Again, assessment. We're crazy people about assessing. We just love the thrill, just like he said. Of the crazy, it's chaotic, it's nuts, but everybody kind of works together. So, okay. Any questions, you guys? So I know I'm going to really try. Okay, I don't know if you guys all know this, but I tried, and I'm really going to push. So you get to spend 4 hours in the ER.